I don't need to tell you there are 8 thumb muscles. And it's all about the balance, like many things in life. There are 2 muscles that control, or cross, I should say, all 3 joints. That's the dorsal apparatus of the thumb, which we will discuss more. There are then 4 muscles which cross 2 of the 3 joints. And there are 2 muscles that only cross the CMC joint. Now I say that, but you're going to learn that the APL is kind of the outlier on that one. The Opponens Pollicis is really the only one you can depend on, only controlling the CMC joint. Now I flew in and out of Heathrow on my way here, and this is the tower at Heathrow. How does this tower stay stabilized? By 3 guy wires, right? Just like the thumb. The 1 represents the first metacarpal, and the 2 represents the second metacarpal. So, adduction, which is innervated by the ulnar nerve, is one of those guy wires. Palmar abduction, pulling the thumb out away, is supported by the median nerve, and the radial nerve extends and abducts the thumb. So if any one of the 3 peripheral nerves going to the hand is injured, you will have some sort of stability problem with the thumb because one of your guy wires is missing. Now, we're going to take each muscle. I'm going to try very hard for this not to be boring. But let's just think about how each muscle contributes, and then we're going to try to pull them all together. Flexor pollicis longus, we already saw, is away from the axis at the CMC joint. We know that it originates in the forearm, and it inserts all the way out on the interphalangeal joint. It crosses all 3 joints. It's only one of 2 muscles that cross all 3 joints. So it flexes the IP, MP, and CMC, but it also adducts at the MP because it is slightly on the ulnar side at the MP joint. And it also adducts the CMC joint. What did we say earlier? You cannot flex your thumb without adducting. So here is one of the contributing forces to exactly that synergistic motion. Now, this is a little bit difficult to maybe orient. This is a cross-section at the level of the carpal tunnel. This is the carpal tunnel right here. These are the thenar muscles, and these are the hypothenar muscles. So there is the flexor pollicis longus. And you can appreciate how far away it is now because it's come all the way over to the carpal tunnel from the thumb. So the moment arm here, you can see, is significant. Here is the flexor pollicis longus, and here is the first metacarpal. Look how far away it is. And it's not quite yet proximal enough to be in the carpal tunnel. But there's no pulley that supports the flexor pollicis longus at the level of the CMC joint. So your FPL is your adductor, and even more so when you're in an adducted position. So if you have someone who is the rare example of radial deviation at the base of the CMC joint, and you have them do this exercise, what are you doing? You're adducting them. You're not just flexing them. So adduction is the contraindication to that radial deviation at the base of the CMC. There's also the Lindbergh-Comstock combination, which I have. I cannot flex my thumb without flexing my index finger. So if you are working with the FPL, it's always wise to go ahead and let the individual flex their fingers. Because if they have that connection and you don't allow them, if you hold them out like this, they can't do it. I hold my index finger out. That's as much as I can do with my thumb. I have to let it go before I can come in. Now our FPL, we think of it as a fine motor, but it's really what we use for every kind of holding activity that we have, whether it's gross or fine motor. We have to transmit force through the FPL. It is the only force going across the flexor surface at the IP joint. And so we need the FPL. Now, you have these in your handout, so I'm not going to read these to you. But these are my understanding from the studying that I've done of how the FPL functions at each joint. And I've listed a primary and a secondary. And then on occasion, I also list a pathological. I did not in the case of the FPL. Now, the Extensor Pollicis longus, the other one of the two muscles acting on all three joints. And you'll notice in this illustration that there's another one going all the way out. See that? We'll talk about that in a minute. So it also comes from the forearm, but it does not come from the proximal forearm. It comes from the distal third, and it inserts on the surface of the distal phalanx. But the Extensor Pollicis longus is really just like the extensors to the fingers, in that the extensor to the finger doesn't go straight out to the IP joint, does it? To the DIP joint. It combines with and becomes part of the dorsal apparatus. The same thing happens with the Extensor Pollicis longus. There is a dorsal apparatus to the thumb. And so it becomes part of that. And it cannot extend the IP joint of the thumb unless the dorsal apparatus moves proximally. The Extensor Pollicis longus sits ever so slightly on the ulnar aspect of the MP joint of the thumb. And so it quite easily can become an adductor. We just said that the FPL is also an adductor. So here you have two of your extrinsic forces, both of which are rather strong adductors, particularly at the CMC joint. When it's pathological, it really becomes an adductor. Now, this is going back to Brand's illustrations, and we're only looking at the EPL. So at the IP joint, the EPL is central. At the MP joint, it becomes somewhat toward the ulnar direction, and then it becomes even more toward the ulnar direction as you get to the CMC joint. So it gets further and further away from the joint, having a longer movement arm to affect motion in that direction. It extends and adducts the first ray, and if you do not have an adductor pollicis, in other words, you have a patient with ulnar palsy, you will see them adduct with it. This is what this lady is doing in the top illustration here. She's using her adductor. Of course, she has a few other problems along with that. But it is the only muscle that can bring the thumb above the plane of the palm. Nothing else can do that. Other muscles can extend the IP joint, which is not true, which is exactly the same as in the finger. So it's the third dorsal compartment. So it's very dorsal. So wrist motion affects the tension and length of the EPL. It's influenced by tenodesis. And it does primarily extend the CMC and IP joint. And it contributes to extension at the MP joint as well. But pathological, remember, it ulnar deviates and adducts, just as we were talking about the FPL. Now, we have to talk about the dorsal apparatus for a moment before we talk about these four muscles, so that we're really clear how everything is working. These four muscles we think of as the nerve muscles, and we think of them as the primary, along with the Opponens Pollicis, muscles moving the base of the thumb. But think about these four muscles, not just moving the CMC joint, but they all insert distal to the MP joint. Now, they don't insert into bone, but they go into, you remember the illustration of where the muscles are going into that capsule. So what you have via these four muscles is an absolute synergistic relationship between the motion at the CMC and the MP joint. And as the CMC joint moves and the MP joint extends, these muscles then contribute to motion at both joints. So the dorsal apparatus is very similar to the finger in that it is an aponeurosis that interconnects both these extrinsic muscles as well as the intrinsic muscles of the thumb. The flexor pollicis brevis and the abductor pollicis brevis go into one side, and the adductor pollicis goes into the other side of the capsule. The Opponens Pollicis is not part of this. The Opponens Pollicis is more proximal, and we will look at that. The muscles, both the thenar muscles in terms of abduction and flexion, and the adductor together are being guide wires. Does that make sense? And they are extending. They're flexing the MP joint and extending the IP joint. Did I say flexing? I think I did. I meant to say extending. So they're extending the MP joint. And the Extensor pollicis brevis, the reason it was illustrated earlier as going all the way out is it's highly variable in its anatomy. And on many occasions, it does go beyond the MP joint and insert along with the EPL. So you cannot depend on it ending at the MP joint. But it almost doesn't matter whether it does or not, because if it becomes part of the dorsal apparatus and it blends in with those fibers, which we know it does, then it's one and the same. It still influences IP joint extension. And that's exactly why if the EPL is lacerated, individuals can still extend their IP joint. They probably cannot hyperextend it, but they can extend it. The dorsal apparatus flexes the MP joint and extends the IP joints. Does that make sense? It's just like the dorsal apparatus of the finger that flexes the MP joint and extends the IP joint. The extensor pollicis brevis is one of those four muscles. It abducts because it's on that side of the thumb, but it's not a strong abductor. But as we know, when it gets down to the CMC, then it has more of a momentar for abduction. It also originates from the forearm, but look what a short, much shorter muscle belly length. It has less excursion demand on it, and therefore it has a shorter. And it's not as influenced by the motion of the wrist, which we'll look at in a minute. So the extensor pollicis brevis is below the axis of the wrist. So if you want to prevent tension on it, you don't extend the wrist. Many people misunderstand that, I think, and they think, okay, it's an extensor, I need to extend the wrist. But because it's below the axis of the wrist, that's not true. And it is in a very lateral compartment. So the good news is that wrist motion does not influence the tension on it as much as it does on one which is in a more dorsal compartment. It is primarily an extensor, but it can extend both of the other joints as well. And a pathological presentation of the EPB would be that it radially deviates. It takes you this direction because it falls in that direction. Now, think about the extensor pollicis brevis and the extensor pollicis longus. And they're both extrinsic muscles. Why they named the extensor pollicis brevis a brevis, I'm not really sure. I guess because it's shorter. But they both insert identically into the dorsal base and out to the distal phalanx for the EPL and the proximal phalanx for the EPB, although we know that can be variable. But look at their actions. They're identical except for the fact that one can serve as an abductor and one as an adductor. Now, we're not talking about it serving as that in isolation. We're talking about it contributing to that direction. The adductor pollicis, the largest, strongest muscle in the thumb. Hard to overcome the adductor once it gets going. If you want to palpate the adductor, though, don't do it from the dorsum because you're on the first dorsal. Do it from the volar aspect because that is then the fibers of the adductor you're palpating directly here. And this goes without saying, palpate it while you're adducting because then that's when you're going to be able to see that it's active. Now, it has this incredibly strong base because it comes from that third metacarpal as well as the capitate at its base. So it's got this phenomenal origin, and it has two heads, so it inserts into that capsule of the MP joint and becomes a very strong force of creating MP joint flexion and IP joint extension. The heads, one goes into the dorsal apparatus and one goes into the proximal phalanx. It extends the IP joint and flexes the MP joint. And it is the single primary muscle bringing the first metacarpal toward the second metacarpal. It's really not a muscle we ever, in my opinion, want to strengthen. We usually want to not have it be the dominant force. That's it right there in green. It does create some ulnar deviation at the MP joint, and of course, usually has no effect at the IP joint, except, remember, it's contributing to the dorsal apparatus, which does go to the IP joint. So everything is interconnected. Most important thumb muscle, the Adductor Pollicis brevis. It's really the one that gets your thumb out of the palm, totally. And it too has a relatively large base because it comes not only from the trapezium and the scaphoid, but also the flexor retinaculum. So it has this sort of broad base. And it inserts via the dorsal mechanism, and it may also or may not have a direct proximal phalanx insertion. But it definitely goes into the joint capsule and becomes part of that dorsal apparatus force. It is superficial and can be palpated, and it's always a muscle you can know whether it's active or not. There's nothing else that would really get your thumb away from your hand. So as it's extending the IP joint and flexing the MP joint, we are rotating around at the CMC joint, and it is abducting. Now here is the Adductor Pollicis brevis, and you can see very clearly, I'm going to back up here. You can see very clearly how the muscle goes into the dorsal apparatus here. You can see it a little bit more clearly here. Here is the joint line. And when the muscle contracts, you can see then that the force goes through whatever this tendon is, whether it's the EPL or the EPB that's extended. All interconnected. And of course, it abducts the CMC joint, and it's also, because it inserts the MP joint on the radial aspect, it is a radial deviator. Now, think about the adductor pollicis and the abductor, right, on each side. Look at their insertions. They are identical, but on opposite sides. Look at their functions. They are identical, but on opposite directions for the CMC joint. They're like the reins on the horse, guiding that middle pole. There, the guide wire is telling the middle pole where it's going to be. Flexor Pollicis brevis. It has two heads. You can see that clearly here. Dr. Mo Bogomil has died. He's no longer with us, and he was extremely generous in giving these images to me, and I'm forever grateful to him. I think they're great teaching images. So its origin, it has a superficial head that again comes from the retinaculum and the trapezium, and the deep head, which is more primarily from bone, the trapezoid and capitate. But they all are secure in the carpal area before they insert. Now, it goes through the radial sesamoid and to the base of the proximal phalanx, but it also goes into the dorsal apparatus. So all four of these muscles affect all joints, even though the textbooks say that they just go to two because of that dorsal apparatus. So extension, impede flexion, and flexion and rotation. Now, this was actually a woman who worked for me, and I needed a photograph, and I said, well, here, just bring your thumb over like this and just flex your MP joint, okay? So the photograph on the left, I said, flex your MP joint. And when I said to her, okay, flex it just a little more, what did her IP joint do? Perfect illustration, wish it had been a video, but perfect illustration of those muscles flexing the MP joint and then extending the IP joint. So flexor pollicis brevis, those are the primary and secondary. Now let's do flexor pollicis brevis and extensor pollicis brevis. Okay, look, insertion is the same, right? Action is the same except for the CMC joint, as you would expect, because they're on opposite sides. You remember the statement I made earlier about thinking about one muscle of the thumb and what it's doing at one joint? It's really hard to do that because these are, they're just tightly integrated and they work so synergistically. Now, the Opponens Pollicis, it comes from same retinaculum, trapezium, there's just a broad base there for all these muscles. And it inserts into the radial side of the first metacarpal. It is the only muscle that really, truly, you can be sure is only moving the CMC joint. But it is by far the hardest muscle to evaluate because it lies under the Adductor Pollicis brevis, and you really cannot easily palpate it. You're not sure you're on it. I have a little bulge of it that I know is my opponent's, but I have very well developed thenar muscles, and not everyone has that. So it's very difficult to know what it's doing. And it's a really large muscle. It's very effective. And it has this broad insertion, so it moves the whole metacarpal quite easily. It is the single muscle that you can depend on rotates the thumb, and it cannot rotate without abducting. Okay? Try to keep the plane, put your thumb in front of your index finger like this. Watch the plane of your thumbnail. Try to bring your thumb out completely and don't let the thumbnail rotate. You cannot do it. You cannot do it. You cannot isolate just your abductor because your abductor and your opponents work together. The trick is always noting the angle of the thumbnail. And the way to do that best is to put something on it. Now, you may want to take note of this and go to it because I'm only going to show you a small portion. This is our website, BraceLab.com, and just write down clinical pearl number 76, okay? But what happened was we had a young woman who worked for us who one day said to me, my thumb hurts right here. can you tell me what's wrong? And I couldn't find anything really significantly wrong with her thumb. I thought, oh, she's too young for CMC, but she's hypermobile. And then I started talking to her and asking her when it hurt, and it hurt mainly when she was texting her on her phone. And she was of the age group to do that all day long. And she actually worked for us, posting some social media, and she did all the posting on her phone. Okay, all day long. Well, when we asked her to get on her phone and allow us to observe, we realized that she really was not rotating her right dominant, I think it was her thumb at all. She used the side of her thumb all the time. So she never used her opponents, and it had atrophied. So this is a video, and there are toothpicks taped to her thumbnail. And look at her attempt on her right. See how much she can rotate on her left? But she cannot rotate the same on her right. Look at the difference. It's just going to play over and over again. So we ask her to do two things. We ask her to do no posting on her phone, do all the posting online through her computer, and we also ask her to wear a thumb brace while she was texting, because the thumb brace abducted her and she could not type with the lateral aspect of her thumb anymore. She had to rotate and use the pulp. And so that way, never during the day was she going back to this repetitive non-use of the Opponens Pollicis. I was startled. I was just startled that this young woman works out, I would call her healthy, that her Opponens Pollicis did not participate in her thumb motion, ever. And her primary complaint was related to something about doing her hair. And she would have thumb pain after that. And I think she must have been in a position where she had to use it, and it just fatigued quickly, and then fatigued muscles aren't happy. So I don't know. But I would encourage you to look at your patients if they're young and they do a lot on the phone. But the toothpick trick is so helpful because it's subtle. It's extremely subtle, and you may not appreciate it. But once you make that visually longer, you can really tell that there's a huge difference. So the opponents, the opponents is our friend. It rotates, and it doesn't really get us into trouble very much, except obviously when we don't use it. So the Abductor Pollicis longus, this is, if I had to give up one muscle in my body, this might be it, I don't know. But it has been proven recently to be a stabilizer, so I guess I'll keep it. But it has a much longer origin. As you can see, it's a very long, thin muscle, even comes from the interosseous membrane. And everyone says it inserts on the base of the first metacarpal, right? Well, if you really look at the literature, yeah, it does. It comes through the first dorsal compartment. Isn't this an extraordinary image? Those are the slips of insertion of an Adductor Pollicis longus. And it's extremely common to have multiple insertions. And for those insertions to not be on the base of the metacarpal, but to extend much more distally. So it's this sort of aberrant an anatomical curiosity that this muscle is so variable. The number of tendons in this study, and look, they had quite a few specimens. The average was 3 slips at least, but some had as many as 6. Exceptional to find a single tendon. So it extends and it abducts, but it's got a very poor movement arm. I mean, it just comes across the CMC joint and it inserts. You know, it doesn't have a good ability to bring the entire thumb back into extension because it's just down here at the base, pulling on the base. So that's why I thought I could do without it. And it's so variable. You know, I mean, you look at the literature, it's just unbelievably variable. So you don't really know what you have in terms of an abductor pollicis longus, excuse me. And one author looked at a deep and superficial head, and both radial and ulnar of the superficial, and a lot of specimens, and look at the different insertions. And it talked about a bursa between the tendons. You know, that may be why we always get in trouble with de Quervain veins. Do the tendons move independently? We don't really know. Perhaps they do. Usually a bursa would indicate that they do, because you don't need a bursa unless there's movement, differential movement. But this author suggests that the deep supports the trapezium and the superficial moves the metacarpal. And it's like, okay, one support, that doesn't quite, is that synergistic? I haven't quite, I thought it wasn't a stabilizer, and a lot of people said that it was not. But I think there's some new work now that is beginning to say it is. Am I wrong? Have I gotten that mixed up? It is not an important stabilizer, I know that. And because it's so variable, I don't know that we can depend on it, because we don't know what we're dealing with unless we dissect out. That's not very practical. And then the question is the first dorsal interosseous, the thumb muscle. Well, if you look at this illustration, you would certainly think it would affect the base of the thumb, and there are various studies that have proven that it does certainly affect the stability of the base of the first metacarpal. It is definitely synergistic with the adductor pollicis, because as we pinch, that is when we need the first dorsal stability. So the irony of ironies, as we're activating the adductor pollicis, we're also activating the first dorsal. We don't want to strengthen the adductor pollicis, but we do want to strengthen the first dorsal. So how do you go about that in a balanced manner? You'll probably figure out by the end of the day that I'm just not the type of person who, I think it's best put to say, I don't put up well with fiddle-faddle. Do you know what that means? I don't like to fuss around. I don't like to, you know, I like it simple, clean, focused, clear. And giving a patient multiple little fiddly exercises would be something that, as a patient, I wouldn't respond to very well. I need something more functional. That's just my personality. I recognize there are very different personalities, and one of you has worked on exercises on your thumb, and I commend you. You've done a fabulous job. But I would also say you're so highly motivated because you're a therapist and you understand the whole picture. I think it's much more difficult for the patient to have that perspective. So I'm not sure how well I would do with first dorsal interosseous exercises, but it definitely is the stabilizer.